paramount. We need to be sensitive to the fact that many patients perceive dentistry as a painful experience.
It's our job to address those fears and make sure they feel as comfortable as possible.
Exactly. And while local anesthesia is our first line of defense, it's not always enough.
Especially for those patients with low pain thresholds or high anxiety,
Right. So that's where those alternative pain management strategies come in.
like pre-medication with anti-anxiety agents or sedatives.
Exactly. Medications like diazepam, alprazolam, or midazolam can be very effective in calming those nerves. But again, we always have to emphasize timing.
An hour before the appointment.
Exactly. And the importance of having a companion present,
Safety first.
always. And then, of course, there's inhalation sedation, nitrous oxide, the old reliable,
It's a classic for a reason.
safe, effective, easy to administer.
And hypnosis.
Hypnosis can be incredibly powerful, but it really depends on the patient's receptiveness to suggestion.
Makes sense.
And then there's electronic dental anesthesia, or EDA.
Yeah, we talked about that earlier. Pretty amazing technology.
It is. It can really make a difference for those patients who are apprehensive about pain.
So many options to choose from. It's all about finding what works best for each individual patient.
Absolutely. A personalized approach is key.
Now, let's shift gears again and talk about infection control.
Infection control, the foundation of a safe and ethical practice.
It's something we live and breathe in dentistry, and for good reason. We have a responsibility to protect ourselves, our team, and our patients.
Absolutely. And it all starts with understanding and following the guidelines set forth by organizations like OSHA.
OSHA, the Occupational Safety and Health Administration, they've been instrumental in establishing those workplace safety standards.
Absolutely. They've given us those protocols for hepatitis B vaccination, universal precautions, personal protective equipment, and proper handling of sharps.
They've also emphasized the importance of meticulous housekeeping, engineering controls to minimize contamination, and work practice controls to reduce exposure risk.
It's a multi-layered approach to creating a truly safe environment.
So we're talking about using rubber dams and high-volume suction to minimize splatter, wearing gloves, masks, and gowns, and disinfecting surfaces and equipment.
Every little detail matters.
And of course, hand washing. It's the cornerstone of infection prevention.
Absolutely. Hand washing is non-negotiable. Before and after each patient, using antiseptic soap, proper technique.
It's like a ritual.
Yeah.
And remember, even with gloves, hand washing is still crucial.
Right. Gloves can have microscopic tears or punctures. You can never be too careful.
Now, let's talk about barrier techniques. They're like our shield against contamination.
Absolutely. Gloves, masks, protective eyewear, hair coverings.
All those essential pieces of personal protective equipment.
And we use them diligently. Changing gloves between patients, fresh masks when needed, eyewear with side shields.
And don't forget the overgloves.
Those are a lifesaver when you need to touch surfaces outside the treatment area.
Help to maintain the integrity of our treatment gloves.
Exactly. And speaking of minimizing contamination, rubber dam isolation and high volume evacuation are key for controlling those aerosols and splatter.
Those invisible enemies.
Studies have shown that high volume evacuation can remove up to 80% of the contamination produced by dental aerosols.
That's impressive.
It is. And then we have the pre-procedural mouth rinse.
Yes, the pre-op rinse. A quick and easy way to reduce the microbial load.
Exactly. Chlorhexidine mouthwash is our go-to.
Now, let's talk about sterilization. The ultimate weapon against those microbes.
We have 4 main methods, starting with the workhorse. Steam pressure sterilization using the autoclave.
The autoclave, the pressure cooker of the dental world.
Exactly. High-pressure steam to obliterate those microorganisms.
But we need to be meticulous about the details. Wrapping materials, instrument arrangement, distilled water, specific pressure, temperature, and time.
Precision is key, and we have different types of autoclaves, downward displacement and high vacuum autoclaves.
The high vacuum autoclaves or rapid cycle autoclaves are becoming more and more popular.
They are very efficient and fast.
Now, for those instruments that can't handle the heat of the autoclave, we have dry heat sterilization using the dryclave.
The dryclave, high temperatures to kill microbes through oxidation, perfect for carbon steel instruments and MERS.
No rusting.
Exactly.
And the chemiclave using chemical vapor pressure sterilization.
The chemiclave, another good option for metal instruments, no corrosion.
And ethylene oxide sterilization.
For those delicate instruments that can't handle the heat, a bit more specialized.
So many options to choose from.
It's all about choosing the right method for the right instrument.
Now let's focus on handpiece asepsis. These instruments are essential, but they also present some unique challenges when it comes to sterilization.
Absolutely. Handpieces are semi-critical items. They come into contact with mucous membranes, so sterilization between patients is crucial.
What are the steps involved?
First, we clean the handpiece with a disinfectant wipe. Remove any visible debris.
Get those little buggers out of there.
Exactly. Then we run the handpiece for a short time to expel any residual water and air.
Okay.
Next, we scrub it with a soap or detergent solution, followed by another air drying cycle.
So it's a thorough cleaning process,
It is. Then we lubricate the handpiece.
using a specialized handpiece lubricant.
Exactly. Expel any excess lubricant because that can interfere with sterilization.
Some practices use automatic handpiece cleaning units.
Those can be very helpful, streamline the process. Once the handpiece is clean, lubricated, and dry, we package it in a sterilization pouch. Then we sterilize it.
Usually in the autoclave.
Usually, but sometimes ethylene oxide sterilization is necessary. Always follow the manufacturer's instructions.
Okay, makes sense. Now, what about disinfection of impressions? We send those off to the lab, so we need to make sure they're clean.
Absolutely. We start by rinsing them thoroughly under running water. Remove any saliva, blood, or debris.
Okay.
Then we immerse them in a disinfectant solution.
What kind of solution are we talking about?
2% glutaraldehyde or a chlorine compound are common choices.
Okay.
The immersion time varies depending on the disinfectant.
And for alginate impressions, we use a spray disinfectant, right?
Right. Soaking can distort the material.
Okay, good to know.
Yeah.
And then we store them in a sealed bag before sending them off.
Exactly. Now let's talk about safe needle handling.
Sharp safety is crucial.
Absolutely. Always use safety needles whenever possible. Dispose of them properly in sharps containers.
And never recap needles.
Right. Use a one-handed scoop technique or a needle retapping device.
Now, what about disposal of contaminated waste
We have designated containers for that. Follow local regulations.
and personal hygiene?
Absolutely.
Yeah.
Professional appearance, short and clean fingernails, no jewelry that could harbor microorganisms.
It's all about creating a culture of safety and cleanliness.
Exactly.
Now, let's shift gears and talk about diagnostic aids in operative dentistry.
These tools are essential for accurate assessments and treatment planning.
They help us to catch problems early and monitor our patient's progress.
And it all starts with the patient interview.
The patient interview. That's our chance to gather information about their medical history, dental history, concerns.
It's also a time to build rapport, establish trust, and create a comfortable environment.
We want our patients to feel heard and understood.
Exactly. Open-ended questions, active listening, empathy.
Once we've gathered that information, we move on to the clinical examination.
The hands-on assessment.
Looking for signs of disease, evaluating existing restorations, assessing the overall health of the teeth and gums.
Mirrors, probes, explorers. A thorough and systematic approach.
And of course, radiographs, those x-rays that give us a peek beneath the surface.
Indispensable tools. Visualize the internal structures of the teeth. Roots, pulp chambers, surrounding bones.
I use different types: bite wings, periapicals, panoramic radiographs.
Each one has its purpose. Bite wings for interproximal caries, periapicals for the whole tooth and surrounding structures, panoramics for a broad overview.
But radiographs have their limitations.
Of course. They're two-dimensional images of three-dimensional structures. We always correlate them with our clinical findings.
And minimize radiation exposure using the LIRA principle.
As low as reasonably achievable. Only take radiographs when necessary. Use digital radiography whenever possible.
Now, what about other diagnostic aids besides radiographs?
Well, there's transillumination.
Transillumination, using light to shine through the teeth.
Helpful for identifying cracks, fractures, areas of decay.
And it's non-invasive.
Exactly.
What about the electric pulp tester?
Ah, the pulp tester. Helps us to assess the vitality of the pulp.
So, we can determine if a tooth is healthy, inflamed, or necrotic.
Exactly. But it's not always 100% accurate.
We always consider the clinical picture as a whole.
Absolutely.
Now, let's talk about caries detection. Early detection is key.
Absolutely. Caries is a sneaky disease.
We have various methods for detecting it.
Starting with a visual examination.
Looking for changes in color, texture, contour, white spot lesions, discoloration, demineralization.
And tactile examination. Gently probing with an explorer.
Feeling for those soft or sticky areas.
But we have to be careful not to damage the tooth surface.
And then there's radiographic examination.
Bite wings for interproximal caries. Periapicals for the extent of caries.
Sometimes we even use CBCT.
Cone beam computed tomography, a more detailed three-dimensional view.
But it involves higher radiation exposure.
So we use it judiciously.
Now, there are some newer caries detection technologies emerging.